Welcome to the second webinar of the Egyptian Association of Pediatric Ophthalmology and Strabismus, hosted by EVA Pharma. In this webinar, we are going to present and discuss a variety of strabismus, pediatric cataract, and pediatric glaucoma cases. I will be co-hosting this webinar with my dear colleague, Professor Dr. Yasmine El Sayed from Cairo University. We are proud to have a prestigious and reputable panel today to discuss and comment on the cases. I'm sure that we will all benefit a lot from their huge experience. In our panel today, we have from our beloved Cairo University, Professor Dr. Lobna Khazbak, Professor Dr. Ahmed Mostafa Abdelrahman, and Professor Dr. Ghada Gawdat. From the Research Institute of Ophthalmology, we are honored to have Professor Dr. Adel Eldeen and Professor Dr. Ahmed Khalil. Last but not least, I would like to welcome Professor Dr. Jamal Bleik from the American University in Beirut, Lebanon. Dr. Jamal is the former president of the Arab Board of Ophthalmology and the former president of the Lebanese Ophthalmological Society. He is also the Secretary General of the Middle East Africa Pediatric Ophthalmology and Strabismus Society. At first, I thought to introduce Dr. Jamal as a guest speaker, but I realized that Dr. Jamal belongs to Egypt as much as we all do, if not even more. Welcome, Dr. Jamal.
Shukran. Thank you for having me today. Shukran.
For the audience, I would like to remind you that at the bottom of the webinar window, you will see two buttons, the Q&A and the chat buttons, where you can send your questions directly to our panel. In addition, during presentation of the cases, we are going to show you a number of polls so that you can actively participate in our debate today. So let's kick off. The first session would be about intermittent exotropia. I'm going to show a bunch of cases and ask the panel about their opinion. So the first case is a 3-year-old girl presenting with intermittent deviation of her classic presentation of intermittent exotropia. Motor evaluation revealed an intermittent exotropia of 25 prism diopters of fair control for distance and of good control for near. Ductions and versions were full. Cycloplegic refraction revealed only a small astigmatic error. So the question to our audience first, what would you do for this patient? Would you just follow up only? Prescribe the spectacles with the minus astigmatic correction? Prescribe an over minus lenses by adding -2 diopter sphere to the prescription? Instruct the patient to do pencil push-up exercises or alternate patching, or just proceed to surgery and do bilateral laterectomy recession. So we are going to launch our first poll, and I'm going to ask our audience to share their opinion. So remember that there is no correct answer and no wrong answer. Just share what you would do in such a case. So this is the result of the audience. Most of them tended to use spectacles with the astigmatic correction. So to our panel. Dr. Adel.
Yes.
We actually, there is a role for active treatment of intermittent exotropia by doing patching, or alternate patching, over minusing spectacles, or are we just keeping the patient busy doing something until you do surgery? Keeping in consideration that you always thought that intermittent exotropia tended to deteriorate over time. However, the last PEDIC study showed the deterioration of intermittent exotropia is quite uncommon in children. So would you prescribe treatment, or would you just leave the patient as is?
First, I would like to express a point that in intermittent exotropia, the main insult was the fusion, what we call that they have a defective central fusion, but they have peripheral fusion. So if we take the first step is to prescribe glasses, my regimen, I have hypermetropia about +2, or I have myopia of -1, or an astigmatic error of 1.5 diopter, I should prescribe glasses for the sake of the better vision and to give a chance for better fusion. As regards to patching, actually, I'm not convinced with patching for this reason. Because when you do a patching, you are decrease the timing of fusion. So I think patching is more hazardous than to leave the child as it is. As regard to over minus lenses, I tried for a long time and I realized it gives a false impression that we have an improvement, especially for far angle of deviation. And I stopped using the minus glasses because it has no effect on the prognosis or after surgical interference. And this can mask the frequency of exotropia. Usually I ask the parents how much the frequency of intermittent exotropia. And this is very important question because usually the child came after the beginning of the insult after 1 year because the frequency was so low and then started to increase, which means we have a progress of the intermittent exotropia. So during the follow-up, if in addition to spectacles, I assure the parents that mostly we can go for surgery, and this depends on the amount of fusion and when it starts to be manifest for far, or if I can check the binocular function and I realize that he lost the fusion starting from far, I start to warn the parents, we will lose also fusion for near, and we are about to reach the surgery.
Adel, you believe then that most patients probably will need surgery, is that correct?
I think so, yes. In the
How
most
about the rest of the panel? How the rest
Except
of the...
if you have a myopia, you should be conservative for a while.
Okay.
What is that? مش سامعك يا أحمد.
Okay, so for the rest of the panel, do you share the same opinion that patients most probably will need surgery, or do you think that sometimes patients would get better by themselves?
May I speak, Ahmed?
Yeah,
actually, because this girl is just 3 years old, I would give her a chance. I would follow her up, and I would see if she's alternating. Yeah, she does not have one eye for preferred for fixation. I would just leave her, and sometimes they improve by time and they regain their fusion, and everything goes fine afterwards. Especially if their control is okay. But if she does not, if she prefers just one eye for fixation and single eye drifts, I would go for patching. Sometimes when she's young, when she's 3 years old, I would go for patching. I would give her something to do, just try to avoid suppression in this eye and try to improve her vision as well. And then I would stop patching afterwards if she improves and she starts alternating fixation by both her eyes.
Jamal, when a patient comes to you like this and tell you what's the chance that I will need surgery, what is the chance or incidence that you give it to them?
Thank you for having me again. If we're talking specifically about your patient who, as I remember from the slide, she is 3 years old and she has good control over her deviation, I would definitely observe her. The classic teaching, and I had my training long years ago with Gunther von Norden, واللي هو كلنا بنعرفه يمكن وكتابه لازم كل حدا interested in strabismus يقراه. It is free online على الامريكان Academy website. We used to ask them if the drift is apparent more than 50% of the waking hours or not. But Enta, in your slide, you said that she's 3 years old, she has good control. And I would tell you and tell everyone here, the nightmare of a strabismus surgeon is to transform a child with good control, exotropia, and full stereopsis into a consecutive esotropia and amblyopia and loss of stereopsis. This is a nightmare. This is a nightmare. And this exactly is a defeat to any strabismus surgeon, that you take a child with stereopsis and you lose the fusion and the stereopsis. So if there is good control, no, I would observe, and I would teach the parents to watch for drift, 50% or more of the waking hours. Also for symptoms, if there are headaches, if there are any symptoms like intermittent diplopia during studying. And I don't do over minus, and I don't do patching. For long years, I've never done that because I was never convinced that it works. And the new studies show that I probably was right, because the effect of medical medical treatment like patching and over minus is only temporary. It doesn't help on the long run. So this particular case I would observe and I would see frequently for any signs of deterioration.
Dr. Ghada, you already mentioned patching. When do you prescribe patching, and what is the role of patching in an alternating squint? Especially that the PEDIC study constructed 2 separate studies in 2 different age groups and was unable to give a definite answer to this question. So do you think that patching has a role?
I do not patch except if the child prefers to fix with one eye and the other eye drifts, because actually we're talking about the intermittent XT. The parents are so much pressured by the surroundings actually, and you're so much offended by the cosmetic appearance of their children. And they come and they say that a single eye drifts or both eyes drift. If both eyes drift, it means that the vision, cycloplegic refraction is almost equal in both eyes. I don't go for patching, I just follow up. But I go for patching if I find that the child prefers single eye for fixation and single eye drifts. It is always the same eye that drifts. So I try to just patch 2 hours per day the eye that fixes, just to promote the vision in the other eye. And I get pleased when both eyes alternate fixation. I think this is a satisfactory thing for the parents and for myself, and I explain to them. And when the child alternates fixation with either eye, he's better like this.
Dr. Lobna, do you believe in alternate patching?
No, I don't believe in alternate patching at all, but I agree with Dr. Ghada. If the patient prefers fixation with one eye, I occlude part-time occlusion of this eye, just 1 or 2 hours per day, to improve visual acuity in the other eye, which tends to drift outwards, and to guarantee that there is no amblyopia in that eye. But alternate patching, I think it is enough.
How about overmyosin? Who from the panel believes in overmyosin or prescribe an overmyos spectacles? Anyone of the panel?
May I answer? I only use over-minus lenses as a temporary measurement in patients under the age of 4 years. If they start decompensation for near. So this helps them to control the deviation for far and near, so that they are not going to develop suppression and lose binocularity. But by the age of 4, I stop the over-minus lenses and re-evaluate the patient according to the new Kessel scoring system. If the score is very bad, I go for surgery.
Ahmed, إذا بتسمح لي بس على over minus, my experience has been an over minus is never tolerated by children who are not myopes. So over minus works sometimes, especially after surgery, if you have a residual deviation or if you want to delay surgery for any reason, but not for patients who are not myopes. So I do over minus sometimes if the patient is originally myope. But if the patient is hypermetrope, it's very difficult, or if the patient is emmetrope, it's very difficult for them to accept an over minus.
I think young age group below 4, they tolerate minus lenses, but above that, they, as you said, Dr. Jamal, they don't tolerate it at all. This is right.
There is always a fear from patients who are given over-minusing that when later on you do surgery, because the child was accommodating for a long time with the over-minus lenses, that he might get an accommodative exotropia or consecutive exotropia after surgery. Do you think this is rational? That he might get more overcorrection after surgery?
In my cases, I don't meet that problem. Okay. Because I don't give them too much over-minus, just -1 or -1.5. Not even -2, and withdraw them by the age of 4 and re-evaluate. So I didn't meet that problem.
How about the role of fusional exercises and orthoptic training, Dr. Lobna?
This is effective in teenagers and in those who can you explain to them what is meant by physiologic diplopia. If the patient does not appreciate physiologic diplopia, this is useless because the push-up, the pencil push-ups, they can see single while the eye drifts outwards. They are monofixators. But when you tell them how to appreciate physiologic diplopia, fixate on the pencil and see what pictures away or near the pencil to be kept seen double, and then approach the pencil to the nose. This is very effective that you increase the fusional convergence. And this is also very effective in those who have convergence insufficiency more. It is effective to transform the intermittent exotropia to phoria in teenagers, but I don't try it in children because they do not understand what's meant by physiological.
Okay, but would you do it for even the basic type or divergence excess, or only the convergence insufficiency?
It is effective in convergence insufficiency, of course, more, not in the other types.
Okay, we have a question from the audience. How common is amblyopia in a case of intermittent exotropia? Is this something that we should really get worried about? Dr. Jamal?
What's the question?
How common is amblyopia in a case of intermittent exotropia? Is this something we really get worried about it?
I think amblyopia is very rare in intermittent exotropia if we stick to the definition. So intermittent exotropia, they have fusion most of the time, or a big percentage of the time, and usually they don't have amblyopia. Once they develop a significant amblyopia, the intermittent exotropia usually becomes constant. So intermittent amblyopia, they do not have intermittent exotropia, they do not have amblyopia in most cases.
You already mentioned, Dr. Jamal, that you don't prefer surgery at young age groups, except it's very indicated. So what's your age threshold for doing surgery in an intermittent exotropia? Dr. Jamal?
Again, the below the age of 3 or 2, I of course do surgery for exotropia, but I'm not sure the patients that I operate fit into the definition of intermittent exotropia. The patients whom I operate are more congenital or early onset exotropia with very large angles, and those are the ones who need early intervention. But intermittent exotropia, I go back to your case, intermittent exotropia, 3 years old, with good control, I don't find any reason to operate. So my age threshold, it all depends on the control. If there is 3 years old with intermittent exotropia, where there is drift constant more than 70 or 80% of the time, I would go for surgery for sure. So the age depends on the case and the fusion percentage of the control over the deviation. Is it good? Is it fair? Is it poor control? This decides more than the age.
Would you modify the surgical dose in such young age group? Would you do a smaller recession or do the same amount of recession as an adult?
Actually, I love unilateral surgery. I love unilateral surgery for exotropia. Nelson, like 10 years ago, published a big series of single lateral rectus recession of one eye only. And he even did that for kids who had 30-35 prism diopter of exotropia, which is too much for me. So anyone who has 20 prism diopters of exotropia or less, if I have to do operation, I like to do a single lateral rectus recession, because as I mentioned, I'm trying to help this patient to better control fusion, to have better control over the drift, and I want by all means to avoid a consecutive esotropia, because the smallest esotropia, if it persists, you are losing your fusion and your stereopsis, and you're transforming the patient into a patient with amblyopia while you started with the patient who had full stereopsis. So I like to do unilateral surgery, except of course if the angle is very large, over 30 or 35, I do bilateral recession, and I don't modify the surgery according to age. What I modified is doing one eye, but I don't modify. If I have 50 prism diopter, I do my usual surgery, bilateral lateral recession with my usual numbers.
Dr. Adel, do you do the same like Dr. Jamal?
Yeah, actually, I prefer symmetric surgery. But again, the time threshold, we don't have a time threshold. As we mentioned, all that fusion is very important factor, and the stereopsis, and the timing and the frequency of intermittency is the factor to decide where to operate or not. Actually, below 3 years of age, the amount of surgery for such young children is more or less a limited number, except if it's congenital, as mentioned by Dr. Jamal. But actually, we usually, as classic teaching, we say that we are going to operate at the age of 4 or 5. But the crucial sign is the increase of intermittency and started to be manifest and starting to lose the fusion for far and for near, and of course associated with stereopsis, which sometimes the detection of stereopsis in children of young age, it is difficult somehow to analyze the stereopsis. So the timing of surgery depends on the situation of the binocularity.
دكتور أحمد إذا بتسمح لي حدا من عم يسأل على السمول أنجل ايزوتروبيا. Not talking about the small angle esotropia for 4 to 6 weeks after surgery. This is desirable and it will go away. I'm talking about the small or moderate angle esotropia that persists for weeks and months. In a young child, it will definitely affect fusion and may induce amblyopia and loss of stereopsis. بس توضيحا على واحد من الأسئلة.
Thank you. We'll move to the next case. This is a typical 21-year-old female complaining of bothersome intermittent deviation of her right eye. The angle is 40 present diopters for distance and near of fair control. Warford dot test showed a right suppression test, and the visual acuity was slightly subnormal in the right side. So this is a patient with a unilateral fixation preference. So the classic question, what would you do for her? Would you do a bilateral lateral rectus recession because it's a more symmetrical surgery and more competent? Or would you prefer a right recession resection because it is the unilateral fixation preference? So let's see what would the audience prefer. I'm going to launch the second poll. So what would you do for this patient? A bilateral recession, or would you prefer a recession resection? So I love this result. It shows exactly what would happen in real life. 60% prefer recession resection and 40% would go for bilateral recession. So it's almost equal. So now to our panel. Now we have several studies that compared bilateral recession to recession resection. The last one is the large prospective study by the Bedic and found almost an equal success rate between bilateral recession and recession resection. So I would like to ask the panelists, what do you think? Is this correct? Do you agree with them that the results are almost equal, or do you prefer one technique over the other? Dr. Ghada.
May I answer, Ahmed? Look, if the vision is equal in both eyes and there is no fixation preference, I would go for BLR, bilateral rectus recession. I prefer more than a unilateral recess resect.
Regardless of the angle?
Regardless of the angle, I would go for bilateral rectus recession if the vision is equal and if there is no fixational preference in either eye. But in your case, she prefers her left eye for fixation, I believe, and she has more intermittent XT more in the right eye. It drifts more, so I would go for recess resect in this eye. Although, and sometimes I get scared of the consecutive esotropia. Sometimes it doesn't. It work fine. I mean, this is in my hands, unfortunately. I like symmetrical surgery more than unilateral recess resect. Although this study proves that recess resect is better than bilateral rectus recession.
Lobna, how about you?
I'm pro the bilateral lateral rectus recession. Recession is more physiologic than resection. It
Even
doesn't. Yes. What?
Even for large angles? Sometimes with large angles like 40 and 50 prints.
Yeah, in large angles, you may do recess resect, or sometimes you need the three muscle surgery.
Three muscle surgery.
Three muscle surgery.
Yes,
so one eye, recess resect, and the other only lateral rectus recession. I don't want to create any incompetence or any asymmetry of the palpebral fissure. So if you have very large angles and you do recess resect, you may be confronted with a little bit narrower palpebral fissure, which is cosmetically sometimes is not acceptable. So try to ameliorate the condition, improve the XT, and also the cosmetic appearance of the patient.
Ahmed, sorry, just before Dr. Adel, in large angles, I'm with Dr. Lobna. Sometimes we might go for a 3-muscle surgery. So, but my preferred technique, if the angle is adjusted with 2 muscles, there be BLR.
What is your definition of a large angle, Dr. Ghada?
More than 35 prism diopters, for example, more than 40, for distance and near.
Dr. Adel?
Yes, actually I have some concern about the amblyopic eye or suppression. So I am afraid of overcorrection and getting an exotropia in such conditions. So we have an option according to the angle. You can operate on one lateral rectus and do additional marginal myotomies. It works actually very nicely. You have the full recession, not more than 9 or 10 millimeter from the insertion, and then you can add some marginal myotomies. It can correct and give cosmetic results. As we know, up to 10 prism diopter is acceptable. If you have a large angle, resection of the same eye for psychological reasons for the patient, of course. And sometimes if you have a larger angle, you can have another option. You do one medial rectus resection to correct this large angle because it gives an effect more than if you do one lateral rectus recession. So you can play with the muscles, and you should avoid to do an overcorrection in such conditions.
Okay, before I move to the next case, I would like to share with you the long-term results of the previous study. The previous study showed that the failure rate at 3 years was almost 50%. This means that at 3 years, we have almost 50% recurrence. So does this mean that the long-term result of intermittent exotropia that poor, Dr. Adel?
Actually, I had a study several years ago and published in ESA proceedings for the stability of the outcome of strabismus surgery. And I realized that error of refraction and stigmatic correction it is a multifactorial actually. Visual problem should be solved. The timing of surgeon is crucial. And even if you are aiming to do some overcorrection to get 10 or 15 prism diopter early post-operative as ESO deviation, they give stability more, even if they will pass to exophoria. This study was showed that if we pass to some sort of ESO deviation, it will affect the stability on the longer term. Actually, the maturation of the visual system and all, we see this by age of 12, you find a jump of the binocular fusion and something like that. I realize this in my practice. So you have always a factor of age and the maturation of the visual system.
Moving to the next case, this is of intermittent deviation of his left eye. Motor evaluation showed an intermittent exotropia of 30 prism diopters of fair control. Cycloplegic refraction showed a significant myopic error, especially on the left side. So for
sorry, we don't hear you, Ahmed.
I have to remind them that for measurement of the problem. Can you hear me now? Hello?
Hello, Ahmed, we don't hear you well.
Okay.
The sound is interrupted.
Okay, let me check. Lobna?
Yes, Ahmed. I didn't hear you. Hello? Hello? Ahmed?
Is better now?
Yes,
Hello?
yes, we can hear you, right?
What's the question? What's the question? Ashan, I didn't hear you.
No, I'm just explaining to the audience that there is a problem in measurement of angle.
Yes.
With minus, because minus lenses act like two prisms, apex to apex. So when the patient looks at the outer part of the spectacles, the outer part acts like a base out prism. And this major angle in order to neutralize the deviation. So if the angle is 25 prism diopters, you need like 35 prism diopters to neutralize the angle. So patient is with a minus lens, the measured more than the true deviation. On the other hand, one would expect the myopic eye being larger.
Ahmed, the sound is not clear, Ahmed.
Dr. Lobna, I think Ahmed is asking about if the patient has a myopic error, how will you calculate the angle?
Investigated this. So what would you do? Would you reduce the amount of recession because minus spectacles overestimate the angle? Or would you increase the amount of recession because it is a myopic eye and you need larger surgery?
This is a poll, Ahmed, or can we answer?
To the audience, what would you do? Yeah,
this is a poll, Ahmed? Ah, okay.
Yes, Paul, yeah, this is a poll.
Okay.
Factors that wants to reduce the amount of recession, factors that need to increase the amount of recession because of the larger globe.
Ahmed, would you put the result of the poll, please?
Yes, I'm putting it now.
Yes.
The result now. Most of the audience were in agreement to reduce the amount of recession.
دكتور لبنى يمكن تعلق احسن لغايه ما دكتور احمد يظبط الكونكشن.
Yes, right. Tolerate me in that to explain. Really, the prismatic effect of minus lenses with the axial length factor. Okay, so you have to properly measure the deviation. If you measure with the high minus lens, as you said, minus means more. So the angle you measured is larger than the actual angle. So you are going to operate on a larger angle than the real angle of the patient, which compensates or almost neutralizes the elongation and increase of the axial length. So you are actually, if you do the measurement with the high minus lens without correction, actually you are doing more surgery, which compensates for the increase of the axial length. As you show on the slide, that the percentage of error is 2.5 times the spectacle power. The problem in hypermetropia and plus lenses is more exaggerated than in myopia. They do not equalize each other and cancel each other. However, the steps you should take. First of all, you should correct the error of the prismatic effect by the nomograms, okay, of Kaufman and Stephen. Then there is a paper published in 2020, depends on or talks about the dose-response relationship, DRR. What is that? They said that the actual position of the muscle you should put should be corrected with factors. This factor is complex. It depends on whether you are going to operate on one single muscle, one single lateral rectus, or bilateral lateral rectus, or recess resect, or 3 muscle. And they put certain figures. So if you want to calculate the real muscle position to compensate for the error in the measurement of the angle due to high minus and due to the axial length, you should take 3 steps. The first step is to calculate the corrected angle for the deviation according to nomogram. The second step is to calculate the total muscle shift according to the DRR, and then multiply the muscle shift by the actual axial length, which is very large, for example, 26 millimeters, divided by the standard axial length, and they consider in the study the standard axial length to be 23.1 millimeters. If you do the 3 steps, you are going to know where exactly to put your muscle, compensating for the error in angle measurement and compensate for the increase in the axial length in myopes.
Ahmed, can I comment quickly?
Yes, yes.
The best thing to do for high errors, myopes, hypermetropes, astigmatism is to measure with contact lenses if you can. Yani ask your patient to come back with a pair of contact lenses and you will have the best measurements. طبعا كل اللي قالته دكتور لبنى applies, but if you can afford having a patient with contact lenses, you will have very accurate measurements usually.
Okay.
But how to compensate for the axial length? How much do you compensate?
No, I'm talking.
This is a compensation for the error in measurement of the angle.
No, I'm talking about the prismatic effect of the eyeglass.
Yes.
So in order to cancel the prismatic effect of eyeglasses, do your measurement with contact lenses. موضوع الاكزيال length موضوع تاني.
Yes.
We have very few questions from the audience before concluding this session. We have a question about how many diopters of myopia you start adjusting the surgical dose, Dr. Lobna?
How many?
After how many diopters of myopia would you consider adjusting the surgical dose? What degree of myopia is bothersome?
You mean the axial length?
This is the question. I mean the myopic refractive error. For example, a -6, -10,
-2. More than -2, you should correct for the error in measurement of the angle.
And we have another question. What is the best surgery for XT for recurrence?
For recurrence?
Yes. Would you re-explore the lateral recti or would you do a medial rectus section?
Sure. If you find any limitation of abduction, you should revise the lateral recti. Whether it is over recessed or you mean
under corrected
consecutive ESO or under correction? Under correction. It depends on you can explore if you have in the files how many number of millimeters recessed. You can recess more. If it is only 6 millimeters, you can recess more. Okay. If it is large recession, you can do medial rectus surgery.
Okay. We have another question. For an immature children, why they will not tolerate an over minus? Somebody is disagreeing with this comment.
ما سمعت.
My opinion is young children below 4, they can tolerate over minus. But older than that, they do not tolerate over minus. They cause headache, astinopia, and they don't tolerate because they have excess use of near work.
The problem, Dr. Ahmed, with over minus إنه ما في أي studies بتقول إنه على long run it is beneficial. يعني
it's a temporary, yes, we agree.
Temporary measure.
Yes, it's a temporary measure. It's a temporary measure.
Okay. We'll conclude this session and we'll move to Dr. Yasmine El Sayed with her interesting glaucoma case. Dr. Yasmine? Dr. Yasmine?
Yeah, I'm here. Yeah.
Okay. Go ahead.
Hello, everyone. So our first case here is a case of glaucoma secondary to Sturge-Weber syndrome. So this young lady presented to our pediatric hospital of Cairo University at the age of 12 years with an obvious port wine stain due to Sturge-Weber syndrome. Her right eye developed glaucoma at the age of 2 years, for which she had multiple glaucoma surgeries, multiple trabeculectomies. An infranasal tube was implanted because the superior quadrants, as you will see, were had very thinned out sclera, and she had multiple diode cyclophotocoagulation sessions. Despite everything, her pressure was still uncontrolled on full topical medications in addition to Diamox. Her vision in this eye was 160, and she had an advanced cupping. Her angle was closed with peripheral anterior synechiae circumferentially. Her other eye, which is the eye in question here that we will launch the poll about, her left eye developed glaucoma at a later stage. She had a trabeculectomy for that a few years back, but then when she came, her pressure was still uncontrolled and she was referred to have some surgery for this left eye. So her pressure was still 24 on full topical medications and Diamox. The vision, this was the better seeing eye, obviously, so her vision corrects to 0.9 with a small minus lens, and she had a cupping of 0.8. We did gonioscopy. This was her angle, so it was more of a premature looking angle. So the first question here about this left eye, let me launch this first poll. So what would be your surgery of choice for the left eye, the better seeing eye? Would you go for an angle surgery, combined trabeculotomy, trabeculectomy, a repeat trabeculectomy, glaucoma drainage device, or a deep sclerectomy? Right, so it looks like there's an inclination to go for glaucoma drainage devices here, having had a previous trabeculectomy, but some would still go for angle surgery or a combined trabeculotomy, trabeculectomy. So let me start by asking our dear panelists, Dr. Ahmed Mostafa, what would be your surgery of choice for this patient?
Yasmine, thank you very much for having me with you.
It's a pleasure.
Yes, the point is, I think there are some data which I need to know before making a reasonable decision about this case. In the first place, I would like to search for a choroidal hemangioma, because this will play a major role in my decision. I think if the patient is having, this patient had previous TRAB, as you have mentioned, yes?
Yes,
And then,
exactly.
yes. Now, if the patient is having a choroidal angioma, is expected in the post-operative period after TRAB is not going to be a nice period. And there might be a period of hypotony and then a rebound elevation of the intraocular pressure. So I think I need to know some factors. First of all, the extent of episcleral angiomas, because actually I think there are some technical difficulties when you have a lot of episcleral angiomas to open the subconjunctival space for any kind of procedure in patients with Sturge-Weber syndrome. And then I need to look for a choroidal angioma, and then I need to make a decision. Then I think I may defer my decision until I present the case that you are going to show.
Okay, great. So Dr. Ahmed, so how would it make a difference whether the patient has a choroidal angioma or not? What kind of extra precautions, or would it deter a certain surgical decision and make you prefer one decision over the other?
Yeah, the point is, you know, what increases the surgical risk tremendously is the presence of choroidal angioma. And choroidal angioma is present in 50% of the cases. So that if the patient is having choroidal angioma, especially if now this patient is a one-eyed patient, yes, then I will think more and more and more before thinking of opening this eye. This is one point. The other point is that if the patient is having a glaucoma, then I need to think where the problem is. Is the problem is in the eye? I mean, is it a difficulty in the aqueous getting from inside of the eye to the outside of the eye? Or actually it's a problem outside of the eye of increasing episcleral venous pressure. Now this girl is 12 years old, and then this is the period where there should be the second phase of glaucoma related to increased episcleral venous pressure. Then generally speaking, if the patient is having a choroidal angioma and the patient is having extensive episcleral venous plexuses, then I would go for a procedure that decreases the aqueous production rather than increasing the aqueous outflow. Because if I'm going to take the aqueous outside of the eye to an unhealthy subconjunctival space, I think the reaction is not going to be as expected. So for those patients in particular, those having choroidal angiomas, I will think of a procedure that you are not, it was not in your list, which is to treat the ciliary body. I know that when you treat the ciliary body, you say cyclodestruction or cycloablation, which is really a very, very frightening word when you hear about that. But what I think in practice, it is rather a cyclomodulation, because you are now having a lot of techniques which are treating the ciliary body gently. And the point is that it's almost extremely rare to get a hypotony. Not only hypotony, but in the postoperative period, you need to do a cyclomodulation, whether by standard continuous wave diode or micropulse or anything else. And probably you need to add anti-glaucoma as well to reach your target. So again, patients having choroidal angioma, I will go for a procedure that will not open the eye.
Great, thank you. Dr. Ahmed Khalil, would you consider posterior sclerotomies in these cases if they have a choroidal hemangioma?
Usually I don't. Usually I don't.
What would be your procedure of choice if they were found to have a choroidal hemangioma, and what would be your procedure of choice if they don't?
If they don't, for sure, it will be a trabeculotomy, an angle surgery, and namely trabeculotomy. The point here is that also, زي ما Ahmed قال, there are many cases which pass undetected. This is a typical goniodogenesis, trabeculodogenesis. This is a typical case which benefits well from a well-done trabeculotomy. They are very responsive to the surgery. However, I remember one case in which I did not detect choroidal angioma, and probably even post-operative I did not detect. And I had a severe hemophthalmos, which resulted in an IOP of 30s to 40s in the first 2 weeks post-operative, exposing us, me, the family, and the girl to, of course, a huge risk. Luckily enough, this girl, I started with the weaker eye. I started with the eye which was more advanced. Actually, eventually, no vision was lost, but I had this severe hemophthalmos, probably caused by the choroidal angioma, probably caused by the high episcleral venous pressure, but it ended up complete resorption with no sclerotomies beforehand, and I didn't even think of sclerotomies. I'm not a fan of posterior sclerotomies in any instance, actually. So it is a combination of medical treatment, it is a combination of proper closure and good follow-up, and usually they are young patients, and usually their optic nerves, they have the power to withstand. So that girl, when the eye I started in, she was, I remember, either counting fingers or something like this. And I started with this eye to experiment. And at the end, after 2 weeks of very high pressure, she was fine. She regained her weak visual acuity. Of course, no improvement, but the IOP was wonderfully controlled. So again, regardless of the previous trabeculectomy, I would still go for trabeculotomy. Of course, as much away as possible from the trabeculectomy side, because the trabeculectomy side, whatever we do, interferes with the trabeculotomy, which will we do either during the surgical steps, during the surgery, or post-operatively. So as far away as possible. Maybe infratemporal is the first location and infranasal is the second. And then again, it is the choroidal angioma. To detect is not the easy answer, but it is like something closed. You go and you do your best to diagnose, but maybe you diagnose and maybe you misdiagnose, but it is not a common instance to have this full hemophthalmos. I was unlucky in one case, but I was so lucky in other cases. So still, I will make trabeculotomy with very proper closure of the scleral flap afterwards.
Great, thank you. Dr. Ghada, how about the cases that do have the choroidal hemangioma that you spot with a diffuse choroidal hemangioma with all the risk of going into expulsive hemorrhage if they develop hypotony? What kind of precautions do you do? Would you prefer not to open the eye? Would you deter surgery? Would you go in with certain precautions?
First of all, the case you're displaying, Yasmine, has this genetic angle actually. And we see a lot of cases like this. So the problem with choroidal hemangioma, if we are going to do filtering surgery, if we're going to enter into hypotony, and I do not prefer filtering surgeries as a primary procedure in these cases. I know that this case underwent trabeculectomy, subscale trabeculectomy before. I would go for circumferential trabeculotomy, supranasal and infratemporal. I would go for that. I would give her the chance of an angle surgery. And if for any reason, any perforation takes place, I would inject Helon, cohesive viscoelastic, into the anterior chamber just to keep the eye pressurized all the time. In addition to this, I have to be so careful in cases of Sturge-Weber. We have to look for if there is any choroidal hemangioma or not from the beginning. And if any perforation takes place and if it converts into trabeculectomy, I have to close the eye so fast, and I have to keep the eye pressurized. I think these are precautions. These make things go in a better direction, I believe, rather than having a suprachoroidal hemorrhage or suprachoroidal effusion.
Right, now my question to all the panelists, whoever is interested to go ahead and answer this, would you leave the eye always on Helon in such cases, whatever the procedure you choose to do? So if you're doing circumferential trabeculotomy, Dr. Ghada, Dr. Ahmed, if you're doing trabeculotomy, would you leave them anyway on Helon or on a cohesive viscoelastic to guard against the hypotony post-operatively, or only if there's a sort of perforation or if you're expecting hypotony?
May I answer?
Yeah.
I would, if my circumferential trabeculotomy goes fine, and if nothing, if the intraocular pressure is not hypotenuse, if I do not have perforation, I wouldn't inject Helon from the beginning. But I simply inject Helon just if I induce perforation or if it turns to trabeculectomy rather than trabeculotomy.
Dr. Ahmed Mostafa?
Now, Yasmine, the other scenario that the patient is not having a choroidal angioma. If the patient is having a choroidal angioma, I will go for cyclomodulation. I am so comfortable about that. But if the patient
which one? Sorry, can you specify which one, Dr. Ahmed? Would you do a diode continuous wave or a micropulse diode? I know you're interested in micropulse diode in yes, pediatric eyes.
You know, we have published a series about the micropulse in patients with recurrent congenital glaucoma, and I don't remember any one of our patients developed
Sturge-Weber, no, yeah,
yes, or developed hypotony, I mean, in the first place. So the point is that any type you can use, because now there are good consensus about the use of the continuous wave of having low power settings with longer duration of exposure, and you do not have to treat the entire circumference. So the beauty about the cycloablation, whether it is continuous or micropulse, is that it is possible to titrate the treatment. So that, yes, you can titrate. The other point, Yasmine, if the patient is not having choroidal angioma. Now, in this case, what's my preferred option? And I think I will go for deep sclerectomy on those patients. If the patient is not having
great, interesting.
And episcleral venous plexus, again, if there is a lot of episcleral, I will not open this space. But if the condition is a bit mild, I can do deep sclerectomy with addition of anti-metabolites. And again, I will not open the anterior chamber, and I don't have to put Helon in this situation.
Okay, Dr. Ahmed Khalil, would you like to add anything?
Not particularly. I mean, okay, I'll add any juvenile glaucoma. I go ahead to surgery. This is the only situation, if I can control by medical treatment, I would actually opt for medical treatment if it is very well controlled, very well tolerated for the patient. This is the only juvenile instance in which I can defer surgery, actually, just for the fear of the fearsome hemophthalmos and choroidal angioma.
Great. All right, let's move on. So a quick review. So Sturge-Weber is part of a group of phacomatoses that is characterized by facial angioma, leptomeningeal hemangioma, and ocular manifestations. Having two out of these three would establish the diagnosis of Sturge-Weber. The most common ocular manifestation is glaucoma, and it's either an early onset glaucoma, and that's the most common because of an angle anomaly, or it may develop at a later stage because of the high episcleral venous pressure from the engorged episcleral blood vessels. There are a few reports of patients developing acute angle closure attacks from ciliary body edema, and some develop it from topiramate because of the convulsions they develop. Sometimes they use topiramate. The second most common is choroidal hemangioma, and that develops in 20 to 70%. It may be diffuse or localized, and the problem is that it may affect vision by causing hemorrhages or edema, and it's a risk always during surgery if hypotony happens. So let me launch the second poll here about choroidal hemangioma, and the question is, how do you screen for choroidal hemangiomas in Sturge-Weber syndrome? Are you satisfied by checking their fundus? Or do you do a routine ultrasonography if you don't find anything in the fundus, or an OCT or MRI? Right, so most people will go for an ultrasonography. Some would be happy doing a fundus examination. If they don't see anything suspicious, they will probably not require any further investigations. Dr. Ghada, may I ask you, what is your protocol in excluding the presence of choroidal hemangioma?
Yasmine, I usually go for fundus examination at the beginning, a thorough fundus examination. And if I find something that's suspicious, I would take the patient and would take him to the ultrasound room, and I would do ultrasound for him just to make sure if there is any hemangioma present there or not. And I would compare both eyes to one another, even if he has a single eye of Sturge-Weber syndrome. But I depend at the beginning at on fundus examination more than ultrasound. I take the patient to ultrasound when I'm suspicious of having, or if I can't see the fundus properly.
Dr. Ahmed Khalil, in cases of bilateral Sturge-Weber, bilateral port wine stains, do you rely on fundus examination? Because sometimes when you compare both eyes and they both have a diffuse hemangioma, it may be missed because they both look equally red. We may not be able to spot it accurately. So do you screen by ultrasonography? What are your criteria to send the patient to do an investigation?
It is actually, yes, I do for all patients, ultrasonography. So it is very meticulous fundus examination, but right, you are very often, you can undiagnose or misdiagnose, or you are not able to diagnose. Remember that diffuse angioma is common, and even it can be missed by ultrasonography sometimes. But these are the two tools you have to do very meticulously by a clever ultrasound specialist and by your meticulous fundus examination. So these two are a must in my practice.
Does anyone prefer OCT or use OCT with deep penetrance to detect the choroid or choroidal hemangioma? Anyone in the panel? No. Dr. Ahmed Mostafa, would you like to add something about the choroidal hemangioma? So this case this is actually your case, and obviously she had a diffuse hemangioma that was very evident by ultrasonography. So did you ask for that for documentation, or just to make sure that it's a diffuse?
Look, Yasmine, when you just look, now this patient had a left eye with a history of radiotherapy, and for that she had a diffuse scar in the retina and optic atrophy. So her choroidal hemangioma was probably treated with radiotherapy. Now we just check the fundus of the right eye. Do you have by clinical impression that this patient is having choroidal angioma or not? It's really difficult to tell. And
it's not very obvious.
Yes, it's not very obvious. And on the other hand, you can have patients having the retina just adherent to the back of the lens from the size of the hemangioma. So that you can have a wide spectrum of the appearance and size of the choroidal angioma. So a case like that, we were not able to diagnose clinically. So the next point, I totally agree with Dr. Ahmed Khalil that we ordered for ultrasonography, and you can see how much the choroid is thickened by the choroidal angioma.
Yes,
so now we know there is a diffuse choroidal angioma, and for this patient in particular, you can see that she has a significant cupping and some vascular anomalies on the nerve. And then we opt for cyclophotocoagulation continuous wave. And then what happened for this patient, her pressure was in the 30s with full medical treatment. Now her pressure is 18 under a combination of beta blocker and carbonic anhydrase inhibitor. So now she is at a safer zone. Now we passed like 4 months of treatment and she's quite stable. Let us see what happened.
Yeah. Thank you for that. Okay, so a quick review on some case reports on Sturge-Weber. Most people tried trabeculotomy, trabeculectomy, and the rationale here is that trabeculotomy addresses the angle anomaly while trab addresses the high episcleral venous pressure. So some found a high failure rate and some found it to be effective. With trabeculectomy, some reported choroidal effusion up to 24% of their patients. Some have tried express tubes, which is something we haven't discussed, but some have tried Ahmed tube with ligation. So by the 6th week, when the encapsulation happens and the ligature would dissolve, the pressure wouldn't drop to very low levels. And I have to refer to a study by our colleague here, Dr. Nader Bayoumi, a great, excellent review from his cases on Sturge-Weber. Interestingly, he found the risk of choroidal hemangioma in only 7% of his eyes, and it could be because of ethnic factors that the choroidal hemangioma does not affect as many patients as previously reported. Some of his patients that he was following with Sturge-Weber developed glaucoma as he was following them. So that highlights the importance of having to look for glaucoma and keep an eye on those patients. And he did a combined trabeculectomy with posterior sclerotomies for these cases. What we would like to do in Abu Rish Hospital, the pediatric hospital of Cairo University, is circumferential trabeculotomy for eyes with premature angles. So for this patient, I opted for a Cahook dual blade trabeculotomy through a 2-site incision. So I did the first incision through a temporal approach, addressing the nasal angle. And then I moved on with another incision supranasally to address the temporal angle. So I would be able to cover as much of the angle as possible. And she's been doing well. I haven't been seeing her for a long time now. It's just recently that she had the operation, but her pressure is controlled up to this point.
Yes.
I reviewed some of the cases we have. Dr. Ahmed?
Is that hemorrhage is the normal you see in
the normal? That's I was expecting it to be more. That's the absolute normal when you excise the strip with the Cahook dual blade. And I looked at the cases we have. So these are the patients we have pictures for. These 2 patients, and these 2 had circumferential trabeculotomies, and they've been following for a while now. They didn't need another surgery. This patient had a left trabeculotomy that cleared his cornea, but 4 years later, he required a trabeculectomy, and this patient had a trabeculectomy around 12 years ago when we used to do TRABs as a primary procedure for these cases. So the options are varied, and I really benefited from the whole discussion about all the possibilities.
Can I add one more point, please?
Sure, Dr. Ahmed, go ahead.
Dr. Ahmed Khalil mentioned that we would like, if the medical treatment is really effective, and we are not going to touch those patients, and we really would love that if the medical treatment is working, we will not touch those eyes.
Absolutely, we wouldn't.
But the point is that I think we're having some restrictions on the medications used in patients with Sturge-Weber syndrome, because we are not luxurious to use prostaglandins if the patient is having choroidal angioma, because it might have some effects on the increasing the size of the angioma. On the other hand, if the patient is having epilepsy, which means that he's having a leptomeningeal angioma, probably there are some contraindications for the alpha agonists on those patients, as it might pass the CNS and cause a kind of more CNS depression. So I think we are not free-handed at the medical treatment, but definitely if we can control medically, that would be great.
Thank you very much. Thank you to all the panelists for these very good points. And I'll give Dr. Ahmed Awadein.
We have one question from the audience. In many of the cases, there is blood in the Schlemm canal due to elevated episcleral venous pressure. Would you still do the trabeculotomy? This is from the audience.
Yes.
Okay. So, moving to strabismus one more time. So this session will be about heavy eye syndrome. I'm going to present a number of cases ranging from simple cases to more complicated cases. The first patient is a straightforward case, a 53-year-old male presenting with misalignment of his right eye. Refraction showed a high myopic error on the right side. Motor evaluation showed the right esotropia of 70 prism diopters and the right hypotropia of 30 prism diopters, and characteristic limitation of elevation and limitation of abduction of the right eye. So, Dr. Adel, what is the diagnosis and what is the mechanism of this heavy eye syndrome? Can you please unmute Dr. Adel?
Okay, now? You do hear me? Smile?
Yes, please.
Okay. This is a typical case of heavy eye syndrome, long-standing esotropia with high myopic error and amblyopic eye. So in such conditions, since Diemer was working on MRI findings of extraocular muscle and the direction of the pulley of the muscle, this was a genius approach to evaluate the extraocular muscle and open a point for diagnosis in strabismus. Actually, when you should consider the anatomical factors, not only for the muscle, the position of the eye in the orbit, the connective tissue and the tenon capsule surrounding the extraocular muscle. In such conditions, due to the bulge of the staphylomatous eye to the temporal side, it causes secondary effect on the intermuscular sheath between the superior rectus and the lateral rectus, in a gap that the globe can herniate through this this opening. And if you go for MRI, we'll find this deviation of the lateral rectus and the superior rectus and confirm the diagnosis. The second option is when we do a force induction test, we find a very contraction of the medial rectus muscle in such conditions.
How is heavy eye syndrome different from sagging eye syndrome? In both
the difference in sagging eye syndrome, it is acquired one at old age due to also to degenerative changes of the intermuscular symptoms, intermuscular connection of connective tissue. In some studies, they found there is a nasal displacement of the inferior rectus, which is causing some hypotropia, and in some cases, it is associated with ptosis due also dehiscence of the superior rectus levator complex. So they are two different, but they have the similarity that if we lose the arc of contact of the muscle, extraocular muscle, with the contour of the globe, you might find especially a vertical anomalies in such conditions.
Dr. Ghada, even though the diagnosis is quite evident, would you still do an axial length measurement and an MRI to confirm the diagnosis?
Yes, I think I would go for something like this. Actually, sometimes the axial length measurement and MRI is a bit difficult in these cases with very huge angle of esotropia, because to get the axial length, he has to move his eye outwards a bit. Sometimes they can and some other times they can't because they have defective abduction. In cases of MRI, if we have unilateral case of heavy eye syndrome and we're suspecting, we have to make a deal with the radiologist at first. We don't send the patient just to do MRI orbit for the extraocular muscles and that's it. No, we have to talk to the radiologist and we have to tell him that we need a quasi-coronal sections for these patients, because they, if it's a unilateral case, unilateral heavy eye syndrome, they usually occlude the other eye and try to make the patient fixate with the esotropic eye to a target or something fixation target in the MRI, and they take the sections of MRI 2 millimeters apart from posterior to anterior, and they start counting, yes, exactly, from this photo, from the optic nerve head to the globe junction, and this is the stage 0, and then they go forwards just to calculate where and to measure the insertions of the rectus muscles and where they are. In cases of heavy eye syndrome, yes, we find that there's a staphyloma. First of all, we have a huge axial length of the globe, and we have a staphylomatous part of the globe, which is bulging between the superior rectus and the lateral rectus muscles. And this is very evident with the MRI. So we find that the superior rectus is displaced nasally and the lateral rectus is displaced inferiorly. And this is what creates the esotropia with the hypotropia that we see. In cases of sagging eye syndrome, I'm sorry?
Which cut should we look for? Which cut in MRI is important?
We have to look for the coronal sections first, and then we have to measure the coronal sections. We have to measure the angle as well, the angle between the vertical line and the angle between the muscles. Yes, exactly. This is the angle. Just to measure this angle between the superior rectus and the lateral rectus. In cases of heavy eye syndrome, this is a staphylomatous area. We find this is a staphylomatous part of the globe herniating between both of them, and we get a huge angle. On the opposite, in cases of sagging eye syndrome, it's a bit smaller than this.
Do you agree that the herniation or the displacement is usually seen behind the equator? So we need to look like at 8 to 9 millimeters? Yes. Okay.
Yes, from the equator, and then you go backwards. Yes, this is where we find it.
So there are several options for treatment of heavy eye syndrome. The easiest of them is to do splitting of the superior and lateral rectus and to do suturing of the half of the temporal half of the superior rectus and the upper half of the lateral rectus, like a partial Janssen. Or you can take a suture of these two halves to the sclera, what is known as the Yamada procedure. Or you can avoid the splitting and just suture the two muscles together, what is known as the Yokoyama, whether with or without a scleral fixation suture. Dr. Jamal, what is your preferred approach in such cases?
Of course, it all depends on what you find during surgery, because you have to do the force reduction test, and the force reduction test during surgery may dictate the surgical approach. I like to do the force reduction test actually not only by holding the eye with forceps, but I do open a small conjunctival fornix incision, passing a very small hook and hooking actually the medial rectus and see how tight it is. This will decide if I need to recess the medial rectus or not. And for the heavy eye syndrome, I do muscle union, the Yokoyama procedure. I do use non-absorbable sutures, but I do take a scleral bite so that I fix the two muscles and I fix the non-absorbable suture to the sclera. So I do not necessarily like in the diagram. So I don't fix each muscle alone, but I do fix both muscles after doing the union with the non-absorbable suture to the sclera before tying it up. And then I decide if I need to do the medial rectus or not. And if I need to do the medial rectus, this is one maybe of the few cases that I sometimes resort to adjustable suture.
So look, how many sutures do you need to take between the superior rectus and the lateral rectus?
Taking more is better, because if you take one suture, it might cheese wire and has a less effect. But if you take one suture and then you add 2 or 3 sutures, it is better than doing one suture. I want just to comment on the difference between sagging eye syndrome and heavy eye syndrome. In the heavy eye syndrome, you should be sure that there is herniation of the posterior part of the globe between the superior rectus and lateral rectus, because sometimes in the sagging eye syndromes may occur in high myopic patients as well, with a very large axial length. But in sagging eye syndrome, there is no herniation of the posterior part of the globe between the two muscles, superior rectus and lateral rectus. Instead, there's this area is occupied by fat or sometimes prolapsed lacrimal gland. And in the sagging eye syndrome, the abduction may be normal. Although in the presence of esotropia and hypotropia, the abduction movement is better than in the sagging eye syndrome and in the heavy eye syndrome. And the great difference, why do we differentiate? Because the management is different. In the heavy eye syndrome, we have to do one of the surgeries you presented, Ahmed, but in the sagging eye syndrome, we can do recess resection.
How posteriorly should you place the suture, Dr. Lobna?
15 millimeters from the limbus, almost at the equator.
How technically?
Sometimes it is difficult. It is ranged from 12 to 15, but not anterior to that. And the point of fixation, as Dr. Jamal said, I'm pro fixation to the sclera, because the loop myopexy, the loop may migrate anteriorly, and migration of the loop anteriorly lessens the effect of the surgery. So fixation to the sclera, whenever safe, so long that the sclera is not very thin, it gives much better effect than without scleral fixation.
There is another modification by Ramesh Kukunaya. He used, instead of sutures, he used a silicone band in order to instead of sutures, in order to approximate the two muscles together, and then he used a waxed sleeve in order to approximate the muscles, because he felt that this might induce less muscle necrosis and avoid the excessive tightness of the muscle. Anybody has experience with using a silicone band in such cases? Anyone in the panel?
No, I don't have, but the reported cases that it might give a foreign body effect, foreign body sensation, and in the series, Chinoy, I think, did that procedure. He had to cut the silicone band because of this complication.
Okay.
I believe it looks like the conventional buckling procedure for retinal detachment. I think it can be tolerated. Yes, yes.
Okay. So this is a classic case with a reasonably good result, but unfortunately, not all cases are like this. So another case, this time things are more difficult. This is a large angle of exotropia, 100 present diopters, and a large hypertropia, and you can see how much is the abduction limited. So the hooking of the muscles is extremely difficult, marked limitation of elevation and abduction, and you can see there is also an element of heavy eye in the left eye. The left eye also does not abduct all the way till the end. So I did him the classic surgery, Yokoyama and medial rectus recession. Patient is much better, but still he's undercorrected. How would you manage and how would you explain this undercorrection, Dr.
Lobna? To start with, there is a study made to judge how much each type of surgery affect the angle of deviation and the scope of each surgery. So they found it's a review article. They found that Yokoyama alone corrects up to 40 prism diopters. Yokoyama plus fixation up to 80 prism diopters, while partial Jensen corrects up to 120, the modified Jensen corrects up to 120 prism diopter. So the choice of the procedure to get more effect is very important. You go for the one which corrects much more than the one which corrects less. The amount of recession of the medial rectus, according to tightness, you can recess the medial rectus up to 8 millimeters, and be sure that before you end the surgery that there is much improvement of the Fuchs adduction test, not to get under corrections. Also, under correction may occur if it is later due to, as I said before, migration of the loop anterior or cheese wiring of the sutures. So if you took more sutures, this is guarantees that the under correction as a complication is less. Also, some authors found that after they did everything to guarantee under correction, the cause of under correction was the nasal displacement of the inferior rectus muscle. So you have to go for the MRI pictures, the coronal section, and to see if the medial rectus is, if the inferior rectus, if inferior rectus is nasally displaced or not.
In this patient, the inferior rectus was very tight, but we already did a medial rectus recession, and we did some kind of violation to the superior rectus and the lateral rectus. Would doing an inferior rectus recession carry a risk in this age group of anterior segment ischemia?
Yes, sure. You may be in a big trouble. Yes, you may be in a big trouble.
So Ahmed, can I say something?
Sure, yes, please, Dr. Jamal.
Usually the anti-correction is not a problem. Point of view are very grateful usually, But those patients, they get diplopia if they are not 100% corrected because they didn't have diplopia before surgery. This eye was not a cause of diplopia. And if you get an under or over correction, then you may get double vision and you may end up with a patient who cosmetically looks much better, but unhappy patient because of the double vision. And here we can use some of the tricks that we were talking about before. Because those patients are very high myopes, decentration of their lenses and eyeglasses can be used.
Prism effect.
Yes.
Prism effect can be used in order to treat diplopia. And diplopia actually is the main reason for them to be unhappy if they are a little bit undercorrected. So some manipulation and having a good optician around can help you a lot.
You think, Dr. Jamal, that this patient would benefit from surgery on the left side, even though he doesn't have hypertropia, but he's still myope and he has limited abduction? Would he benefit from a surgery on the left side?
It all depends if the force reduction test after your surgery on the right eye is free or not. If there is any tightness or restriction, whatever you do on the left eye will not help much. But if the movement, if the medial rectus was very tight and you release that, and after the muscle union, the right eye is freely mobile, then definitely surgery on the left eye may help.
Okay. So the next case is also a case of a heavy eye syndrome. This patient has a right esotropia of 90 prism diopter and also a large hypertropia of 50 prism diopter, and again the limitation of abduction and the limitation of elevation on the right side. But the trick here that when she looks down, you can see that she has a very large area of superior thinning and staphyloma, probably in the place of the right superior rectus. What would you do in this case, Dr. Jamal? Would you refrain from surgery, or would you still go ahead and do surgery for
her? Actually, this is a large staphyloma. It's a bit scary. I would definitely do, I don't do sclera patch graft myself. I refer them for my glaucoma colleagues. I have a couple, two glaucoma specialists working with me. So they do a sclera patch graft for such a case. And I would advise to do that before attempting muscle surgery. Because your muscle surgery, especially in such cases, you want muscle union, there is usually restriction, and you are actually inducing more pressure on the eye. So it's not a very good idea to manipulate such an eye without first preparing it with a scleral graft. And I would do this as a separate procedure before attempting muscle surgery.
Dr. Adel, would you do something different for her?
I think this eye is very risky actually, and I think it is a myopic eye, dense amblyopia, and it's an old age or it's medium age, and he's asking for his correction of strabismus or for this bad appearance of staphyloma.
No, just for the strabismus, cosmetic appearance for the squint. That's all.
It is very difficult actually. So considering clear patching and see what is going on. Maybe, and at the same time, you can make a release of the medial rectus in association with patching, maybe.
But excuse me, how long will you stay after this clear patch graft just to operate on the patient?
What?
How long will you stay? How long will you stay after this clear patch graft to work on the patient? Because this is in the area of the superior rectus. So, did you do it, Ahmed?
No, actually, the patient refrained from surgery because many surgeons told her that it's too risky. So she ended up afraid of doing the surgery.
Yes.
Okay, this is
better for your good luck.
She's a wise patient. She's a very wise patient, actually.
And saved you a lot of troubles.
Yes,
saved you a lot of troubles.
She saved you, actually.
Yeah.
This is the last case in our series today. This is another case of heavy eye syndrome. This time he does not have a large hypertropia. The main problem was in the esotropia, almost over 100 prism diopter with only a tiny bit of hypertropia. He had also a limitation of abduction in the left side this time and a limitation of elevation of the left eye. So I went ahead and did a Yokoyama with the medial rectus resection, and 1 month postoperatively, he was slightly overcorrected of about 20 to 30 prism diopters. probably this overcorrection will get less with time. But how would you manage this overcorrection, Dr. Alei?
If there is, I see, if there is marked limitation of a deduction, you can advance the medial rectus. Or if not, you can, if you take 2 or 3 sutures, you can cut the posterior one, so to lessen the effect of surgery. I think so. But if the deviation persists, because I'll be glad to see such overcorrection second day post-operatively, and wait until the eye goes to its place in the orthotropic position.
Jamal, did you ever try to take off the sutures of a Janssen or hemangioma or any transposition? Did you ever try to reverse it before?
This question is to me?
Yes.
No, I didn't.
You ever get an overcorrection and you try to take off the sutures to reverse it?
I think a new patient here, when he looks to, as Lobna said, when he looks to the right, there is a definite limitation of medial rectus. So I'm not sure I want to go in and cut the sutures of the muscle union. Maybe it will be better to attempt to advance the medial rectus again in this particular case. And answering your question, I didn't have to go in and cut sutures again of muscle union. No, I didn't. But I don't always do the medial rectus. So maybe that's why I don't see a lot of overcorrections.
Okay. Dr. Adel, do you have any other thing to add?
I think the first surgery, the key point is how much is the restriction of the medial rectus or the contraction of the medial rectus, and to test the movement of the muscle after your surgery. Here in such case, advancing of the medial rectus, but I am not rushed for second surgery immediately. I can wait for another contraction of the medial rectus, hopefully, if he will adjust by a slight contraction of the medial rectus to adjust it to a 10 prism diopter. I think this will be satisfactory. And if after 3 to 4 months it is still the same overcorrection, we can make an advancement of medial rectus, but not taking the sutures of myopexy.
Ahmed, did you attempt a force reduction test in the clinic for this overcorrection? Did you try after the surgery? Yes.
Actually, the patient was pleased because he was bothered that he cannot see well of the eye. This is one of the main indications for heavy eye. That this patient wanted to do the surgery only to be able to see the eye because it's not in the field of vision. He did not have any kind of double vision, so he was pleased that he could see this eye. So he didn't do anything further. The problem
I understand, but I mean, did you do a force reduction test in the clinic
to
know if there is restriction or not?
No, I didn't do actually. So there's a question from the audience. Is there any role for lateral rectus resection in cases of heavy eye syndrome? Dr. Lobna, do you ever consider lateral rectus resection in heavy eye?
Resection? No.
Yes.
No.
Even in undercorrection, even as an augmentation to the Yokoyama?
No. If there is undercorrection?
Yes. Just a way to augment your Yokoyama or your muscle union. Would you combine this with a resection?
Resection? No resection.
No resection. Anyone in the panel would do a lateral rectus resection in such cases?
No, actually, the surgery for such cases is originally unpredictable. So we are doing the minimum of approximation of the two muscles, and if we have a positive force reduction test for the medial rectus, and according to the angle, actually, you attack the medial rectus. If you have a minimal angle of esotropia, you just be restricted to myopexy of superior and lateral rectus, no resection.
Thank you, Dr. Adel. Now we'll go to the last session. Dr. Yasmine, she's going to present an interesting case of glaucoma.
Right, so our last case today is a case of secondary glaucoma to microspherophakia. So this patient presented to me at the age of 6 months. She gives a history of glaucoma. Her parents say she was born with it. She had bilateral goniotomies and followed by bilateral combined deep sclerectomy trabeculotomy. Her parents reported the cornea being better before the first surgery, and the evidence is that the first surgeon was able to do a goniotomy. But by the time I saw her, the iris was completely adherent in both eyes to a superior opacity. So the decision at this point was to go in and do a pupilloplasty, or an opening in the center of the pupil to recreate the pupil so that she develops a central visual axis. But as I was doing this, I noticed that the anterior surface of the lens was very convex, and as you can see here, the edge of the lens was quite central. So I realized I was faced with a case of microspherophakia. This is her second eye. Again, same operations, developed an opacity later on, and I did the UVM, and it confirmed the diagnosis of microspherophakia. And in addition to that, she also had trabecular dysgenesis, which is known to occur in patients with microspherophakia. So obviously, this is not your typical everyday case of microspherophakia. I just wanted to point out the importance of ruling out, or not to overlook secondary glaucomas to microspherophakia in suspicious cases that are not responding to multiple surgeries, that have shallow anterior chambers. A more common presentation would be probably an anterior dislocated lens causing pupillary block, or a lens that is because the laxity of the zonules or the weakness of the zonules is moved forwards, resulting in glaucoma either due to pupillary block or other mechanisms. So the mechanisms of glaucoma in cases of microspherophakia are basically either pupillary block from an anteriorly dislocated lens, or a lens that is still in the posterior chamber but moves forwards because of the laxity of the weakness of the zonules. In other cases, the lens may cause some recurrent attacks of angle closure of pupillary block, resulting in trabecular dysfunction and synechial closure of the angle over time. And in many cases, microspherophakia may be associated with a developmental anomaly, so an immature angle in these cases, just like the primary congenital glaucoma patients. So the triad of angle closure glaucoma in any age, at any point, with a shallow anterior chamber and refractive myopia should alert us to the possibility of microspherophakia, and should be able to exclude it just to make sure, to manage the patient as a secondary glaucoma. So let me launch the first poll here. I'm sorry, I'm not able to launch the poll for the microspherophakia case. So that's 7. Yeah.
Yes.
Okay. So, well, in such a case, in cases of secondary glaucoma to microspherophakia, what is your preferred surgery to start with? Would it be a lensectomy, glaucoma surgery, combined glaucoma surgery and lensectomy, or it depends on the case? Right, so it looks like it will depend on some factors, and we'll discuss these. Some would prefer to go for a lensectomy straight away. Very few people will go for a glaucoma surgery to start with. So let me ask the panel, Dr. Ahmed Khalil, what would be your first surgery of choice, and what would it depend on in cases of glaucoma to microspherophakia?
Okay. So I'm actually very happy with the result of the poll, because the glaucoma surgery is the lowest percentage, which I totally agree. I have done this for some time, and I totally stopped this now. There is nothing like glaucoma surgery alone in microspherophakia cases. So in any instance, it has to be a lens surgery. And the problem is, as you mentioned, is pupillary block, narrowing of the anterior chamber angle, and probably some adhesions ensuing later on. So if the case comes to me late, which is, I'm talking about 10 years old, 12 years old, some advanced cupping and a longer history of glaucoma, I would go ahead straight to combined trabeculotomy and lens surgery or lensectomy. If the case happens, and this happens actually with brothers and sisters, rather because they do not present early. I have a girl who's 10 years old, so her brother is coming for many times visiting with her. So, okay, let me check that boy, and then I find this Spherophakia and what I call starting glaucoma. This is a totally uncupped disc, very normal disc, but the pressure is 23, 24, 25, which is high for that age. So at this stage, this boy is starting the glaucoma, starting the high or the rise of the IOP. And in this child, I mean, if it is early in the process, before ensuing of peripheral anterior synechia, I would go for lensectomy alone. So in any case, it has to be lens surgery. It is either alone if you can detect it very early in the process, or combined with angle surgery if this child comes to you later in more advanced stage.
Thank you, Dr. Ghada. Is there any scenario where you would go ahead and do a glaucoma surgery in microspherophakia and defer lensectomy for a later stage?
This is a very difficult question, actually, Yasmine, because sometimes it's so hard to risk the lens as well. Sometimes in cases of microspherophakia where the lens is stable in its position, it is not causing a very high myopia, it is not mobile. And simply by performing gonioscopy for this child, and sometimes anterior segment OCT, we find that he has a dysgenetic angle, just a dysgenetic angle, but the lens is not mobile and it is there in its place. Sometimes I have to go for angle surgery, just circumferential trabeculotomy, and that's it. And I tell the parents that his lens, if we have to keep an eye on this patient, because if his lens gets mobile or anything, he might be needing a removal of his lens. Actually, these cases I do not encounter with this scenario that much. I usually encounter the other way around, which is patients having a spherical lens and they're complaining of very high myopia. And on examining them, we find that the intraocular pressure is high, they have shallow ACs, and the angles are nearly occludable. So the only solution then is just removal of the lens, and then I wait for the glaucoma. And most of them, some of them, if they don't have synechial closure of the angle, they get okay, and we just follow them up even without any anti-glaucoma treatment. And if they require, sometimes they just work fine with one eye drops, for example, just one medication. That's it. If they need glaucoma surgery afterwards, we go for glaucoma surgery afterwards.
Dr. Ahmed Mostafa, in case of a pupillary block with a lens that is still posteriorly located in the posterior chamber, would you go for a PI or a lensectomy or do a combined lensectomy glaucoma surgery? Dr. Ahmed Mostafa.
Yasmine, let me have the other side of the coin of a child like 8 to 10 years old, which I really have in my clinic, and presenting with an acute attack of glaucoma. And then when you have those patients, the pressure is usually 50 to 60, and then you will find the pupil is dilated, and then you can see the lens occupying the pupil. And at that time, you are not really quite sure, is the lens anteriorly dislocated completely, or is just the lens is moving forward, so that I have this scenario. So what happened that I started full medical treatment, and I thought that would help. And then after a while, just kept the patient with me at the clinic. And then I realized that now I feel as if the lens has moved into the anterior chamber. The point is that never use myotics if you think that this is an acute congestive glaucoma due to microspherophakia. You might think that the whole lens is the anterior chamber. Now let us constrict the pupil and then remove the lens. Now this will never happen. Why? Because the lens is having a thick anteroposterior diameter. So that what will happen, you're just seeing the anterior part of the lens, and the pupil will constrict on the posterior part of the lens, doing more aggravation of the glaucoma. So the condition here is just you need to dilate the pupil. If you can do that, dilate the pupil, and then give full medical treatment. You can give some kinds of vitreous dehydration. And then I go for lensectomy, of course. I go for lensectomy in this eye. And definitely when the eye is in acute attack, if the patient is 8 to 10 years, which is the typical scenario, I don't put an intraocular lens because the eye is really in a very terrible state, and we need to control the pressure and then get the eye quietened and then think of what we are going to do for the rest of the management. Now, the point is that we need to think of the second eye, because it's like a mirror-like picture. So I went for lensectomy on a much, much quieter eye, and then I re-implanted this patient after 6 months with phakic for iris-supported intraocular lenses. Now, the point is that her brother is 5 years old and is having a similar condition, and still the eyes are quiet. Then what are the options to be done here? I think this is a very good question for discussion.
I will need a whole new
yes,
a whole new poll. That's a very important question. The patient that's not complaining.
Yes, let's go for that. Yes.
Yeah, that's important.
I think
I'm glad you touched on the importance. Yeah, Dr. Jamal.
If you allow me quickly,
absolutely. Yeah,
we have some villages here in Lebanon where microspherophakia is common, and because of the genetic background, and we tend to do PIs much earlier for the siblings. So the first child who
Dr. Jamal? Dr. Jamal? Dr. Jamal, I think it's Dr. Jamal that got disconnected for a while. Okay, we'll go back to him in a while when he reconnects. Dr. Ahmed, I'm glad you touched on the point about dilating the pupil, because if this patient had a pupillary dilatation early on at the stage where the cornea was clear, the surgeon would have probably realized. Dr. Jamal, sorry, you got disconnected. Can you repeat, please? You said that microspherophakia, you do PIs for those because they're endemic in your region.
Yeah, we do PIs for the siblings, because the first child who presents is usually advanced, and they usually present with already established glaucoma and synechiae and adhesions in the angle and so on. So we tend to bring the siblings earlier, examine them, and tend to do PIs for them. And just for the sake of the discussion, many times in microspherophakia, we need to do the lensectomy because of refractive reasons. It's not always because of
absolutely
glaucoma.
Yes, absolutely
yes.
Absolutely, that's a very great point to raise.
Yeah, it's very difficult to adjust their vision, and it induces amblyopia, and sometimes we need to go in because of reasons other than glaucoma.
That's very true. And I'm videos just to show how much the lens moves forwards, even if it wasn't in the anterior chamber. Intraoperatively, if we decide to go for an angle surgery, once the eye is a bit hypotenuse, the lens tends to move forward. So it's always a question at the back of minds whether we have to remove it as well, even if it's not causing pupillary block. So our next question here is how to manage the microspherophakic lens. So back to cataract surgery, and Dr. Ghada, if you would comment on this video that I borrowed from you, because you reported on a technique that you used for managing microspherophakic lenses.
This child did not have glaucoma actually at that time. I just did him gonioscopy, and he had this genetic angle. Actually, he was not presenting with high intraocular pressure. He was just presenting with a mobile lens. I injected high viscoelastic, high density viscoelastic just behind the spherophakic lens, and I entered through the cornea and through the equator, two sides of the equator, just not through the cornea, sorry, this is pars placata. I entered through the pars placata to the equator of the lens with MVR at either side, and then I introduced my irrigation at one side and then the clutter on the other one, and I aspirated the lens matter intracapsular, inside the capsular bag. And then after removal of all the whole cortical matter, I removed the capsular bag and I did proper anterior vitrectomy and I closed. I don't remember that I implanted in that child. And I followed him up afterwards just for the glaucoma that I thought that he might be having later on.
So you use the helon basically to cushion the lens so it wouldn't move backwards?
Yes, that it wouldn't move back. I didn't want it to fall in the vitreous. So I cushioned it with the Helon GV at that time, and I just supported it, and I entered through two sides, pars placata to the equator of the lens, and as I just said right now.
Dr. Jamal, would you like to comment on this technique, or whatever technique you prefer? Does anyone use infusion, insert an infusion to avoid the lens from falling back?
I actually do the same like Dr. Ghada, except that I don't use pars placata. I do it through the limbus. And I do transfixate the crystalline lens first, and then with the vitrector, I do the lensectomy and remove the capsular bag, and I don't implant a lens in such cases. So it's the same basically technique, but I do it through an anterior approach, of course, with anterior vitrectomy.
I think, may I comment, Yasmine?
Sure, absolutely, yeah. Please do.
I think putting infusion into the vitreous is also very important to build up the tension posteriorly, which prevents also the fall of the lens posterior. But the technique of Ghada, I do the same, supporting the lens, going through the equator, supporting the lens with the infusion and aspirating all the lens matter inside the capsule, and then cutting the capsule and eating it up the last thing. This is a very good technique.
You know, Dr. Lobna, I always feel that infusion cannula is the vitreoretinal surgeon's stuff. So I try not to mess up with this. I just get scared of this.
But now we are using it a lot, especially in secondary implantation. Yes, so you have to get used to it. Yes, especially Dr. Ayman is one of the pioneers in retina.
Yes. Yes, but he wants always connect to the lenses that I fell for.
Dr. Ahmed Mostafa, you have something to add?
Actually, it depends. If this eye is not glaucomatous and it's just the patient, you know that removal of the lens would save him from glaucoma and would solve his refractive problem so that the eye is quiet, there is no glaucoma. I actually go through corneal incisions. I'm so much of an anterior segment surgeon. I don't like to go. It is just, I'm very comfortable with corneal incisions. And then I place an intraocular lens at the conclusion of the surgery. I remove the lens, I put myotics, and then I go for iris claw lenses in the same sitting if the eye is quiet and there is no evidence of glaucoma.
May I have to
Dr. Adel?
Yes. I have different scenarios for a familial case, actually. The father was presented at age of 3 with acute attacks of angle closure glaucoma and even the adherence of the lens to the cornea. So at that time, I did him a lensectomy, as you mentioned, to relieve the tension. But actually, he developed resistant glaucoma, and he had repeated surgeries. And then he came with his child, who is about 1.5 years, and he has a bilateral spherophakia. So I start to be conservative, giving Medriatic, make full examination to see the gonioscopy to detect that if you have anomalies or not. And I warned him that if you have any abnormality, and I will make a close follow-up for any subluxation, I will go immediately for lensectomy by fixation by irrigating cannula to fix the lens to avoid its slippage. And I do biometry concerning the parameters of iris claw lens, because myopia here is a lenticular type. So if we have a normal axial lens and we have calculated IOL can be used, I use iris claw lens. The other point that we should concern in such cases, in most of these cases, could be associated with systemic disorders like homocystinuria, Margisani, and
yeah, that's a very important point.
So systemic examination is very important. Cardiac echography is very important, because if you are going for urgent surgery, if we have an immediately angle closure glaucoma, so we should be ready for such condition. And usually, if you start to interfere early without any further complication of angle closure glaucoma, they follow without development of glaucoma in their life. But you should be cautious for pseudophakic or ephakic. This is another issue for we should concern about.
Double mechanism, yeah.
Second,
yeah. Yeah. Okay, thank you. We will move to the last point here, and that's managing aphakia. We touched on that a bit. Dr. Ahmed, I borrowed this picture from you of a ophthalmic eye that's implanted with an iris claw. The problem is they always look a bit wobbly, the lenses, especially with bigger globes. The iris claw looks very tiny compared to the size of the globe. Do all the panel agree on having iris claw lenses for ophthalmic eyes after spherophakia, microspherophakia removal?
Yeah, Yasmine, may I
Dr.
answer?
Jamal?
Oh,
yeah. Dr. Ghada, go ahead, sorry.
It depends on the corneal diameter actually.
يمكن دكتور غادة رفعت ايدها اول بس.
لا I'm sorry, I did not see حضرتك.
I'll take comments from everyone, yeah, because this is this is one of the important.
Anna, for me, any eye, we know from the infant aphakia study and from many other studies, then any eye that has glaucoma or prone to have glaucoma, you are inducing glaucoma by opening the eye again. So any secondary surgeries, especially if not extremely necessary, are better to be avoided. So I don't think this is a great idea to implant an iris glow lens in an eye that was previously ophthalmic and had glaucoma surgery and had good control of the IOP. Leave alone. That's what I think.
And so you prefer to leave them aphakic, and luckily most of them have a small plus. I mean, they wear a small plus refraction, so many of them don't require an IOL implantation to start with. So that's
Absolutely. This is the only advantage of ophthalmos, that it corrects its aphakia by itself.
Yes. Yasmine, after Ghada, I'd like
Dr. Ghada? Okay. Dr. Ghada?
Yasmine, I think I would go for the corneal diameter. The corneal diameter is fine. We don't have a huge corneal diameter, not exceeding 12 millimeter, for example. I would go for secondary IOL implantation, either secondary or even primary. In the last case, when I just removed the lens, if the condition is fine and everything is stable, I would go for intraocular lens implantation. Yes, I use glow lenses. I use them in the AC, anterior chamber, and I use them retropupillary sometimes. I do not go for scleral fixation because I do not like it in glaucomatous patients, but I would go for glow lenses. I would just try to correct their aphakia if the corneal diameter is fine.
Dr. Ahmed?
Yasmine, I think the cornea is a factor in decision making, because if you look at the picture to the right side, and I think this is a very this is almost a decompensated cornea. No, it's almost a limitless cornea, which is the cornea to the right side. So it means that it's a borderline cornea with the endothelium is a bit, it's a very borderline endothelium. So
I think it has to do, maybe can we ask Dr. Ahmed Khalil? Dr. Ahmed, is this the intraoperative picture, is it because the resolution isn't great, or did the cornea look that hazy intraoperatively?
Actually, yes, right you are. It is a bad microscope surgical picture, actually. So the cornea is not that bad, but Ahmed is right. I mean, sometimes you have a corneal edema. The point I'd like, but without interruption of Ahmed, let Ahmed finish, and then I'll have.
Okay, Dr. Ahmed Mostafa.
No, it is just if the cornea is borderline like that, and then and especially if the pressure is borderline, and then it's better not to reopen this eye again, like Dr. Jamal just said, and then spectacle correction would be a great option for those bilateral eyes.
Yasmine, may I have a comment?
Sure, Dr. Lobna, go ahead, please.
Iris glow lenses, I started to implant iris glow lenses in teenagers, not in children, in very young children, starting from 10 years. But I faced a problem because of trauma. Three of my cases are exposed to trauma, whether with a ball or with a punch during quarreling or slap. One of them was slapped by her father on her face, and one of the claws disinclavated and causes localized edema as it touches the cornea. So it is risky in teenagers to have iris glow lens in the anteriorly because of this problem, which may end in corneal decompensation, which is a very serious complication. So I abandoned really using iris glow lenses in that age group. Also, iris glow lens, I think, in very large eyes with, as you said, Yasmine, with wobbling and moving, it causes low-grade inflammatory response, which causes pseudophakic glaucoma, and you are going to go through another problem you created by this wobbling and movement of the unstable iris glow lens in a very large eye. Also, iris fixated lenses, scleral fixated lenses in large eyes are not practical. because if you go with hard PMM scleral fixated lenses with 10O Prolene sutures, the suture which reaches the limbus is going to be very large, and the lens is going to be unstable and with tilt, which creates high order aberrations, which is not in favor of the visual acuity and the outcome of vision. Also, when you try the scleral tunnel technique or the Yamani or the four-flanged technique, the same story is if you try to put foldable IOL, 3 pieces, you are going to distort the normal curvature of the haptic. And the lens is going to be unstable and tilted, which is also creates high order aberration. So in large eyes, I think it is better, much better to avoid opening the eye again, to avoid complications. And also these patients are exposed to retinal detachments incidence, higher incidence. So opening the eye again is going to create a lot of problems. So leave it alone and untouched, better. But if the corneal diameter is okay, you can do implantation, whether primarily with the lensectomy or later on, which is maybe safer.
Dr. Yasmine?
Ahmed,
Adel, okay, we'll take one last comment. Dr. Adel, would you like to comment on that? Because we have to close.
Understanding for the audience, if we have a case of spherophakia presented with glaucoma, with large globe, the main target is to remove the lens and keep the eye with spectacle, because it is already large and he has a valuable myopia, and we don't implant. On the other hand, the cases which are cold cases, as I mentioned, and on the right side of your slides, it's better, and you do axial lens measurements and biometry, and you find that you have a valuable hypermetropic error. If you don't implant, we use the iris screw lens. As regard to the friction of the iris screw lens, it is already a convex one. There is no touch between the optical part and the iris of the pupil, rather than the usual anterior chamber IOLs. We have continuous irritation of the angle. So the effect of iris dispersion from the glue lens, actually with the studies, it is very minimal. And also in the endothelial effect, and I think we have the paper together, it is not significant impact on the corneal endothelium.
Right, thank you very much. Now I'd like to thank you all. We've come to the end of this webinar. It's been really a pleasure. Everyone, all the panelists, Dr. Jamal Bleik, it's been a pleasure to have you from Lebanon join us today. Thank you all, Dr. Lobna, Dr. Adel, Dr. Ahmed Mostafa, Dr. Ahmed Khalil, Dr. Ghada Gawdat. Thank you for your very important remarks, and hopefully we'll come to get back together in another webinar soon.
Yes, thank you, Ahmed.
Thank you very much.
And your effort.
The next webinar should be on next Tuesday at 9:30 p.m. Same time next week, inshallah.
Thank you very much.
Thank you and good night, everyone.
Thank you.
Thank you. Good night.